Welcome viewers, my name is Janelle, and in this video I will be discussing some breast cancer topics, including my own cancer story, and defining what margins are in order to help you be your own advocate during your cancer journey. A quick summary of my cancer journey. I was diagnosed with stage 2 triple-negative invasive ductal carcinoma in September of 2021. I palpated the mass myself because I was pregnant at the time and was hyper aware of changes happening with my body. I had chemo, gave birth, finished chemo, then had a lumpectomy followed by radiation and treatment with Keytruda. My last Keytruda infusion was in January of 2023, and my cancer returned in November of that same year after having a clear mammogram in April. I had a mastectomy in December of 2023. Luckily, my lymph nodes were not involved both times. So, working in pathology as a histotechnologist, I already had a better than your average patient understanding of breast cancer. For those who don't know, which is pretty much anyone I've ever talked to, a histotechnologist is the person who makes your biopsies or surgical tissue specimens into microscope slides for a pathologist to review and make a diagnosis. I am by no means an expert, but I've been doing this job for over 15 years. Although I had this breast cancer knowledge, I of course wanted to know more, so I dove into research about my type of cancer and everything that goes with it. I can't stress to you enough how important it is for you to have a good understanding of your disease, and if you don't, find someone in addition to your doctors who can help you understand. My biggest motivation in my research was to help me decide between a lumpectomy and a mastectomy. I even made a pros and cons table for each to help me decide. I ultimately landed on a lumpectomy because studies have shown that breast-conserving surgery plus radiation is just as effective as a mastectomy at preventing metastasis and death in early-stage breast cancer. Even though triple-negative breast cancer has a higher rate of recurrence than other types, the chemo had shrunk my tumor, and I still had no evidence of metastasis. Both choices had their own set of risks and consequences. You really never know the right answer. You just have to do what you feel is best for you and hope that you have some luck on your side. This brings me to my main topic, surgical margins. After my lumpectomy in May of 2022, I was able to go over my pathology report with my doctors, who were happy to report all of my margins were clear or negative, meaning there was no evidence of tumor on any of the inked edges of the tissue that was removed. Now, when a surgeon goes in to remove a tumor during a lumpectomy, the goal is obviously to remove the entire tumor, but they also try to remove some of the surrounding tissue just to make sure they get all of the bad stuff out. When the tissue is removed, it is sent to pathology where a pathologist or PA will gross the tissue. This process involves using several different colors of ink to cover the entire specimen. Each color of ink is assigned to a different part of the specimen, superior, anterior, medial, etc. This is so when the pathologist looks at the slides made from the specimen, they will see the color and know which part of the specimen it came from. That, in turn, will help guide the surgeon where to take more tissue out during a re-excision surgery if the slides were to show cancer cells on any of the inked margins. The lumpectomy specimen is cut up into several slices, then a histotech will cut thinner than paper slices of those and mount them on microscope slides to be stained and reviewed by a pathologist. Margins are considered negative when there are no cancer cells present at or on the ink. However, there can be close margins, meaning there are cancer cells present very close to the inked margin. That was the case for one of my margins. I had cancer cells less than 1 millimeter away from the ink. Look at a ruler and realize how close that is. I was uncomfortable with that result and expressed my concerns with my doctors. They assured me that as long as there were no cancer cells on the ink, there is no greater chance of recurrence than someone whose margins were larger, and that the purpose of radiation therapy is to kill any lingering cancer cells that may still be lurking in the area. I accepted their reassurance, but thoughts of concern still floated around in the back of my mind for the following months. After completing treatment and having my first post-surgery mammogram come back clear in April of 2023, I began to feel a little more hopeful. However, that was short-lived. I began to have pain and knew that my pre-scheduled surveillance breast MRI would likely show my cancer had returned. After finding out it had, I knew my only option was to have my breast completely removed. During recovery from that surgery is when I found the research article, Margin Status and Survival Outcomes After Breast Cancer Conservation Surgery, Prospectively Registered Systematic Review and Meta-Analysis. You can check it out for yourself on bmj.com. It's an analysis of 68 studies from 1980 to 2021, including over 100,000 patients with invasive breast cancer. There is one major takeaway message I want to highlight from this analysis, and that is that involved tumor on ink or positive or close, no tumor on ink to 2 millimeters. Pathological margins after breast conserving surgery for early stage invasive breast cancer are associated with an increased risk of local recurrence. Patients who develop local recurrence have an increased risk of developing distant recurrence and of death from breast cancer. This association was present despite adjustment for the use of postoperative radiotherapy and chemotherapy. Positive or close margins were associated with increased distant recurrence, local recurrence, and lower overall survival compared with negative or wide margins, and, importantly, close margins without tumor at ink were also associated with increased distant and local recurrence. The American Society of Clinical Oncology guidelines in 2014 suggested that tumor margins, invasive cancer or ductal carcinoma in situ, not touching ink at the specimen edge, are acceptable. But the relatively weak evidence available to address this issue was recognized. The study does not support the overall conclusion expressed in these guidelines. A margin of no tumor on ink is inadequate, and they recommend a minimum tumor-free distance of 1 millimeter from the margin for either invasive disease or ductal carcinoma in situ to ensure optimum oncological outcomes. A related article entitled Width of Excision Margins After Breast Conserving Surgery for Invasive Breast Cancer and Distant Recurrence and Survival says that close margins are important because pathological assessment provides a representative sample of material examined. Occult foci of disease occur beyond the apparent edge of cancers and might not be adequately treated by adjuvant treatment, radiation and/or chemotherapy. My lumpectomy revealed multifocal residual cancer, meaning instead of one single mass of cancerous tissue left over after chemotherapy, I had several smaller patches of cancer cells left over in the tumor bed. The tumor had an overall reduction in size but wasn't completely eliminated. Is it possible that one or more small foci of residual cancer could have remained just past the inked margin, causing my recurrence? Current international guidelines need revision to account for these findings. Recognizing that wider margins might require further surgery, decisions about re-excision should be the product of an informed discussion between clinicians and patients. The issue of involved margins after breast conservation might not be routinely discussed with patients, but patient advocates believe that complete surgical excision to prevent distant recurrence was more important to them than cosmesis, preserving desirable cosmetic appearances. Involving patients with cancer in discussions about margin clearance before surgery should be an essential part of informed consent for surgery. Increased surgical focus on adequacy of margin excision would improve breast cancer survival worldwide. These research papers were published in September 2022, 4 months after my lumpectomy. If I would have had this article in hand while reviewing my lumpectomy pathology report with my doctors, I would have insisted on a re-excision surgery. There is no way of knowing if my cancer recurrence was from missed cancer cells, just beyond the margin, or just a new development, and none of my doctors are at fault in any way. It is impossible to examine every single cell. It just would have at least reassured me I did everything I possibly could to prevent recurrence. My discovery of these articles came too late for me, but not for you, which is why I felt compelled to share them. And since these articles are relatively new, your doctor may not even know they exist. Discuss these issues with your doctor and weigh the risks and benefits. There is no one-size-fits-all in cancer treatment. Knowledge is power. Do your research, fight for your health, and be your own advocate.